Hello everybody, and welcome to the Wednesday edition of Video Clips. Almost forgot, another day has gone by. And today I want to share some data from major institutions ranging from the National Institutes of Health and Dr. Fauci to Malcolm Kendrick, who is a doctor who works as a family practice physician in the National Health Service, several mainstream medical journals, and I think it will help you to make some sense out of the COVID-19 data that can sometimes be very confusing based on terminology in particular. So this particular article I'm quoting from was written by Malcolm Kendrick, the physician that I mentioned earlier, but he takes a lot of his information out of medical journals. I've quoted some of the same articles, and it's very easy, for example, to go on YouTube and watch some of Dr. Fauci's videos, and you can verify a lot of what I'm saying. So the article starts out by saying, in February of this year, Dr. Fauci predicted the virus was akin to a severe flu and would therefore kill around 0.1% of people. And the fatality rate predictions were somehow mixed up to make it look like it was a lot worse than what he originally said, and we're going to talk about how that happened. So it really was the difference between 0.1% and 1%, which doesn't seem like it would be very much. But you confound that with a lot of terminology like cases and case infection rate and all this kind of stuff, these numbers and initials that get thrown around, and it can be very, very confusing. And I think that what I'm going to talk to you about here will explain why some people have been very frightened. You know, we wonder why people are scared and really think that they should be terribly frightened, and I think you'll see what I'm talking about here. So where did the 1% come from? Because 1% of the world's population is 70 million people, and that's a lot of people. If we were talking about 70 million deaths from COVID, that would be significant. It would mean 3.2 million Americans dead and 670,000 in the UK. And I think that based on the statistics that we're looking at right now, that's absolutely not going to happen. So where did it come from? So in order to understand, you have to look at terminology, and I've spent a lot of time with this mainly because of needing to be more familiar with these numbers in order to write a book about it, and also to listen to what experts are saying in terms of some of the expert witnesses who are working on our case. Well, first there's the infection fatality rate. We call that the IFR. This is the total number of people who are infected by a disease and the number of them who die. And this includes people who don't have any symptoms or mild symptoms, those who stayed at home, coughed a bit, and that sort of thing. But this is everybody who had the disease and the number of them who died. Then there's the case fatality rate, and this is the number of people who actually had serious symptoms, who were probably sick enough to have been taken to a hospital or to an emergency room. Now, people who are really seriously ill, these would be people we call cases, are going to have a higher mortality rate than just people who are infected, because one of the things that we're learning from serology testing is that a lot of people in the United States and all around the world have been exposed to the virus, and just like all cold viruses and flu viruses, exposure doesn't necessarily mean you're going to get sick, because some people have really strong immune systems and they clear it right away. So this means the CFR, or the case fatality rate, is always going to be higher than the IFR. With influenza, the CFR is around 10 times as high as the IFR, and COVID seems to be about like that. So you don't want to get these numbers mixed up, because if you do, according to Dr. Kendrick, you can start scaring people half to death, number one, and also lead to public policy decisions that are probably not in everybody's best interest. So on February 28, 2020, an editorial was released by the National Institute of Allergy and Infectious Disease and the Centers for Disease Control and Prevention. It was published in the New England Journal of Medicine, and it stated, quote, "The overall clinical consequences of COVID-19 may ultimately be more akin to those of severe seasonal flu." They added that influenza has a CFR of 0.1% approximately. One person in 1,000 who gets it will die, all right? But that quoted CFR for influenza was 10 times too low. They meant to say the IFR, the infection fatality rate for influenza, was 0.1%. That was the mistake that got made. And then the mistake was compounded. On March 11th, the same experts testified to Congress saying that COVID CFR was likely to be about 1%, so one person dying from 100 who fell ill. Now, I think everybody here can understand the difference between 1 in 100 and 1 in 1,000 is huge, right? Absolutely huge. Well, at this meeting, they compared the likely impact of COVID to flu, but they used the wrong CFR for influenza, the one that was stated in the previous New England Journal of Medicine editorial, 0.1% or 1 in 1,000. That was 10 times too low. So, flu total, 1,000, COVID total, 10,000. They matched up 1% CFR of COVID with the incorrect 0.1% of flu. Suddenly, COVID was going to be a whole lot more deadly. If influenza was going to kill 50, COVID would kill 500. If influenza killed 1 million, COVID would get 10 million deaths. So that's part of that misunderstanding, is part of what led to this domino effect of people panicking, making room for, clearing out hospitals, building temporary hospitals and convention centers, and etc. So, if you were thinking about going back to that figure for the United States, if we were looking at, for example, 3.2 million people dying in this country, that would actually be incredibly cataclysmic. That would be cataclysmic, and I agree, everybody. In fact, there isn't any measure that the government would take that I would disagree with if I thought that it would actually prevent 3.2 million deaths. And I think that almost all Americans would make that sacrifice if that was the case. Well, let's look at data so far. The UK has had around 40,000 COVID deaths, less than 0.1%, but not that far off. With swine flu, which is often used as a comparison, the IFR started at around 2%. At the end, it was 0.02%, 5 times lower than the lowest estimate. So the more you test, the lower the IFR will fall. And that brings up another thing, which is that we are doing an enormous amount of testing. And so what you get is a huge number of positive tests, but that really lowers the death rate, and we don't pay as much attention to that as we can. So where would we look to get the most accurate numbers? Who's reporting out there the most accurate numbers? And according to this physician, it's Iceland. Last week, the week that this article was written was last week, so the week before, Iceland's IFR stood at 0.16%. It can't go up from here, it can only fall. So people can't start dying of a disease that they don't have. It means we'll probably end up with an IFR of about 0.1%, maybe less, not the 0.2% of swine flu. This is worse than swine flu. But it means that we've had the deaths that we're going to get. And if you take a look right now, the hospitalizations are down, deaths are down, generally speaking. What's up is cases, all right? And this business about cases, I think, is something that we need to spend time on, because we call a positive test a COVID case. And remember what I said in the beginning of what Dr. Kendrick wrote. He said a case is a person who has symptoms, often symptoms serious enough to be taken to a hospital, emergency room, or committed to a hospital. Because let's face it, how many times have you had the flu or somebody you knew had the flu, and they didn't seek medical attention unless it was really serious? They just stayed home, they got over it, went back to work, right? So only the cases that we know about generally are the people who are seriously ill. So what we're calling a case now is somebody who has a positive test and has a tiny amount of virus in their system. Now, if you test positive, you're a case, and that's never been done before in medical history. Now, whether or not it's a good idea, this is a discussion we're going to have probably in the courts, and we'll be sorting this out probably when they put me in the ground in another 40 years. I'm planning on sticking around for a while. So we'll sort out what we should call a case. But I think the point to make is that never in the history of public health have we done this amount of testing in order to report on a daily basis the number of people who test positive for having a tiny amount of virus in their nose, or a blood test that shows positive. So anyway, the bottom line is we panicked. First of all, there's a lot of panic associated with this. And I think that that's another public health issue that we need to take a look at. You know, the goal of public health should not be to panic the public. It should be to accurately assess data in order to make appropriate decisions. And one of the unfortunate problems that we have is that we're not going to ever probably know who actually was a case, symptomatic case, versus who wasn't, who died with COVID versus of COVID. In fact, this is probably the worst job that's ever been done on public health data gathering. And at some point in time, we'll have to hold those people accountable. In the meantime, I don't think we did much to protect elderly people who have always been more likely to die as a result of flu during flu season. And what we did do is invest an awful lot of effort in protecting kids who have almost no risk. In a couple of instances in which children were reported to have died from COVID, those records were adjusted. And of course, I've said this before, the publicity associated with correcting the record is never as much as the publicity associated with reporting the bad data, right? So we sent the kids home with unbelievably bad consequences, and I still feel that the draconian and psychologically unsound environment of schools, there's just absolutely no reason for it. Kids aren't carriers, they don't get the flu, it isn't serious, and I think most responsible parents keep their kids home from school when they're sick. I know that when I was a kid, that's what we did. So anyway, here's the bottom line. This confusion over numbers, you know, it's amazing the misreporting of a number can make such a huge difference. And part of the problem is in the whole frenzy that erupted over this, a lot of decisions were made that were very foolish and turned out to be not such a good idea. And we panicked people. And one thing that I'll mention to you, there seems to be, I read yesterday to you the advice that came from the British Columbia health minister. People, even in the healthcare field, are starting to wake up. I read in our newspaper a couple days ago, the former director of public health, Dr. Amy Acton, was given an award by Ohio State University, and her talk at that particular event was about the devastating effect of fear. Well, she participated in that quite a bit, and I think it's an incredible public acknowledgement that maybe that wasn't such a good idea. She didn't come out and say she was wrong, but she did talk about the devastating effect of fear. So you can understand, you know, what the screw up in the numbers really was the difference between thinking that millions of Americans were going to die versus a few more or a few less Americans than would normally die of seasonal flu. One of the big differences, this is the first flu season in the world in all of time where humans have sat glued to the television set to watch these cases rise, and every time somebody died, it became a big deal. I personally think that anytime anybody dies, it's a big deal. Not all deaths are avoidable. And if you try to live life or organize society around making all deaths avoidable, you create a perhaps risk-free existence, but an existence that nobody, at least nobody like me, wants to live. So I'm hoping that this kind of information can be used to address some of the people who still remain terrified about all this and think that they're at great risk of getting COVID and their kids are at risk, and that they need to constantly take precautions and that sort of thing. And by the way, precautions you should always take. In other words, we take precautions when we drive. I do. I fasten my seatbelt. I drive the speed limit. I don't run stop signs and red lights, and I don't drink alcohol and go drive, and I don't take drugs and drive, and so that's taking precautions. When you cross the line to just insane ideas is when you say the risk of driving is high. I'm not going to do it. I'm not going to pull my car out of the garage. Some people might make that choice. It's not a choice I want to make, and I think one of the things we have to do is start truing up the numbers and then throwing the challenge out to people and saying, listen, if you don't want to go anywhere because you're afraid, stay home. But some of us do want to pull out of the garage and go somewhere. And based on the numbers, I feel comfortable doing it. So I should be able to do it, and you can stay home. And just think about it. Peggy Hall is becoming a good friend of mine. I really respect her. And by the way, if you want information on a lot of things, her website is terrific. She's out in California. But one of the points that she makes is that suppose it was the other way around. Suppose that instead of saying everybody wears masks, the government said nobody can wear one. Well, if you were a vulnerable person who was really worried about this, that might tick you off. Well, we did the same thing in reverse. So I'm all for, let's have a sensible conversation about the right data. And I think this is probably a good video to pass on to somebody who is maybe a little open-minded, maybe not on the same page we are yet, but open-minded enough to consider that a view of the numbers, now that we're starting to see what they really look like, might make them less concerned about all this. My email address is pampopper@msn.com if you're welcome to email me. And while we're talking about people being afraid, I'll mention that we offer teleconference group sessions for anxiety and depression, both COVID-specific related and not. And also we have a special class for adolescents between 15 and 20. A little bit different age group and different issues for that age group. So pampopper@msn.com. That's it for today. Pass this on to people who you think would enjoy learning the truth about all of this, and I'll be back to you tomorrow with more news.